enthusiastic people still in the audience. I also, well, was or probably is still one of you. We all want to put epidurals. We all know that it's a gold standard for giving pain relief, especially in labor. And I'm sure you also know that, well, there have been some problems, and there are some times when you do not put epidural, or you say that, well, there are limitations. And that's exactly what I'm going to talk about. Oh, that's what I'm going to talk about. Well, we all know that epidurals says that please relieve my pain. And we are humane people, and anesthesiologists are actually the most humane people in the medical faculty. So we should be looking after that, and certainly it has got lots of advantages, not only to the mother but also to the baby. So, but before we put the epidural, we must know when not to. And some of our colleagues, especially this one, she believes that I produced half a team. I mean, what's your problem? I never had any pain relief. What do you want to have? And so some of the obstetricians, midwives, they also are probably reluctant to have their patient to have a pain relief. And there are reasons. They believe that, well, it increases the duration of labor versus the section rate versus instrumental delivery rate. It gives backache, it causes nerve damage, and all what's not wrong. But, well, it's certainly not true. Because if you compare lots of statistics, lots of studies initially, the retrospective analyses, they did say that, well, when you put epidural, the section rate is going to go up and the duration of labor is going to go up as well. It's not true. You see the recent meta-analysis, it says that, well, first stage will go up by, say, around 40-42 minutes, and the second stage by 12 minutes. We are talking about just 1 hour of a difference. But with that, you are giving excellent pain relief. What about section rate? Same true really. What about instrumental delivery? Same true really. It does not increase this instrumental delivery. The reason in past, what we used to do was, we didn't have low dose concentrations, we didn't have any infusions, we didn't have any, sophisticated devices which give you a computerized integrated patient control epidural analgesia. So we were giving high concentration of local anesthetics by law, and it's not wonder that, well, they were getting paralyzed and they could not push. The baby's head could not rotate in the second stage of labor. So they were getting more instrumental delivery, and section is no more true now. Backache. Every single patient will ask you, we have heard that epidural gives you backache, is it going to happen to me as well? All of you, what do you say, yes or no? Correct, you are my friends. It does not cause backache, yeah? Well, it will cause backache if you have been, like a sword player, like if you hit lamina, if you hit bone, you still drill it multiple attempts, then yes, it's going to cause inflammation and backache, but we don't do that, isn't it? If we don't get it, then we don't drill the bone, correct? And that really should be the case. Otherwise, yes, you will cause backache. But none of the studies will prove, have proved that epidural per se causes backache. Most of the time, the backache is because of the pregnancy itself and the effect of hormones there. Timing of the epidural, too early, too late. I think one of you in the workshop this morning asked about false labor and that kind of thing. Well, I leave it to that decision of the obstetricians. If the obstetricians say, okay, you can have epidural, first and foremost, no one calls you, no patient calls you directly. They will call the obstetrician, they will get examined, and then they will make a decision whether to go ahead or not. And it was until 5 or 6 years ago that people used to believe that you should not put epidural unless the cervical dilatation is at least 3 centimeters, if not more. It's not true, it's changed now. Because two big meta-analyses, one from China, from Nanyang University, it enrolled something like 13,000 patients, a very big number. And none of them could show that it worsens the effect of epidural on any of these parameters what we look at. So yes, by all means, if the obstetrician has called you, the patient has called you, well, English is just saying, I'm 1 centimeter, but I'm still having pain, go and do it. That's what at least I do. It's not late. Breastfeeding, well, there are some media reports, as you know, media will thrive on such things, where they said that some of your thing will reduce the oxytocin, so breastfeeding may get affected. Not true. I think my colleague Dr. Ravindran already told you about contraindications. There's certainly a definitive limitation if you have abnormal coagulation and certain diseases, some around anticoagulant, sepsis, you don't do that. Relative contraindications, we all studied this when we went for MD, so need not spend any time on that. Certainly I will be careful with the metal working back, because you have technical difficulties, and unless you got to get the ultrasound out, you may not know which path you need to go. What are the limitations after we have put epidural? So we have convinced the midwives, convinced the obstetrician, convinced the patient, mother-in-law that we are going to go ahead with epidural. But what are the limitations after that? Well, you can have immediate problems, which are like maternal hypotension. We know spinal anesthesia, epidural anesthesia gives maternal hypotension. But with a low dose, 0.1% levobupropion or ropivacaine, or even 0.125% of either of these drugs, along with fentanyl in there, it does not really give you hypotension. But if it does, I mean, you're not going to leave put the epidural and walk away and go for shopping. You don't do that. You always monitor the patients. And yes, I mean, if you have a hypotension, you treat it with either phenylephrine, if not ephedrine, or a combination of both. Because you definitely don't want a maternal hypotension to cause fetal effects like fetal bradycardia or NRFS, which is non-reassuring fetal heart rate. There was a concern about loss of contractions, and it is true actually. When you put epidural, you will see loss of contractions, because with epidural, your oxytocin level does drop, your adrenaline level drops. Yeah. How often you see the patient sleep after you get epidural? Obviously, the part of it is the effect of fentanyl, but part of it is that because they were awake because of the pain. The pain goes away, they sleep. Many times we see that. Yeah. Also, sometimes the internal rotation in the second stage can get affected, and hence probably this loss of contraction can give you a problem. Having said that, it's so transient that they will come back after 15 minutes. Same is true with the fetal bradycardia. Pruritus, which is itching. I mean, some patients do have problem with the itching, and it is completely because of the opioid what you put in the epidural space. Yeah, fentanyl, morphine, buprenorphine, what not you put, you do get itching and pruritus. Actually, some of them do have, the incidence is quite high actually, 40 to 60%. I mean, jokingly I tell that, well, you have a husband, I mean, he is not doing anything, you are doing all the work, your husband has worked 9 months ago, but now you see you are here now, so ask him to just do some massage, yeah? And most of the times you have never even called that, oh, the itching is so bad that I peel my skin off. It has never happened. Having said that, if you feel in your practice that is a problem, you can give a small tiny dose of naloxone, around 20 micrograms, 30 micrograms. It will not reverse the effect of any of the analgesia. You'll be fine. Patients sometimes shiver. True, very true. Some patients get maternal hyperpyrexia. Yeah? But maternal hyperpyrexia is not a troublesome thing. You should never ever forget that the patient is getting temperature. You should always treat it and look for the other causes. You may even want to give antibiotics, but it's known that with epidural your temperature can go up by 1 to 1.5 degrees, and there are various reasons. I'm not going to go into that because of the shortage of time. You can have local anesthetic toxicity. So yes, these are the limitations, isn't it? And your retention. Quite often when you have put a CSE, combined spinal epidural or epidural, patients can't void, patients can't pee. Then you require another thing, which is like catheterization. Having said that, even if you don't put epidural, you still have urinary retention because of the pain, and that can be actually more troublesome. You maintain the analgesia by various regimens. I think it has been already covered in this in quite length, that you can have various regimens like continuous epidural or PCEA, patient going with analgesia. But if you are doing your own practice in a very small setup, then you might want to invent your own regimen, because obviously when you do epidural, you need to know when to top it up, and you have some facility and some backup for that as well. If you give too high a concentration of the local anesthetic, I mean, if you exceed 0.25%, or if you give even a low dose for a very long time, like 12 hours, 14 hours, 16 hours, then yes, you can have motor blockade, and then that will affect the second stage, means basically the mother will not be able to push the baby out. Problems like block does not subside, or a breakthrough pain. The breakthrough pain very often happens. The incidence is quite high, as 20 to 30%, and there are various causes. One of the causes is putting the epidural too deep, putting the epidural too small, short length, and not giving the correct concentration to give a patchy block. I mean, these are some of the things which will give you breakthrough pain. Sometimes the epidural has just fallen out. Very big patient, you have just put 4 centimeters, patient moves, it falls out. Breakthrough pain is very troublesome. Patients will not like it. They will not forget you. If the epidural is already in there, what problems can happen? Well, you are never going to leave the patient home. You are not going to leave the patient home if the epidural is there already in the back. But if it is too deep, as I said, patchy block, unilateral block, inadequate block, and that's what I meant actually, that if the problems can be with removing the epidural catheter as well. Sometimes they can get knotted. Yeah? Sometimes you can have shearing of the catheter. And I have seen one that the patient actually, the epidural just didn't want to come out because it was knotted. So what we did was we left the patient, we cut the epidural catheter outside the skin, and then at later stage we consulted a neurologist, neurosurgeon, and neurosurgeon actually took it out. That happened a long time ago. I'm talking about nearly 16 years or 15 years ago. But apart from that, it has not happened, and that happened because of the catheter, and they have changed completely now. These days the catheters. Any question time? I think 2.5 minutes still saved. I'm from Pune. What about this?